Hi, Seth again. I'm going to take you through decompressing a suspected tension pneumothorax. So what that means is basically inserting a needle into the pleural space to let some of the trapped gas out and hopefully reinflate the lung. So some of the indications for decompressing a suspected tension pneumo is increasing respiratory distress, hypoxia, hemodynamic deterioration, a patient with a high index of suspicion, such as a chest injury patient receiving IPPV. They're particularly prone to getting TPTs. So what you need to do is you need to assess whether it's a simple pneumo or a tension. So some of the signs and symptoms, uneven breath sounds, they're certainly not an exclusion criteria. Low SpO2 on room air, subcutaneous emphysema. Some of the signs and symptoms of suspected tension, any of the following plus or minus the signs of a simple pneumothorax, such as increase in peak pressure in a ventilated patient or a stiff bag when doing BVM, decreased end-tidal CO2, distended JVP, poor perfusion, increased heart rate or hypertension, decreased LOC, tracheal shift, which is the late sign, and low SpO2 on supplemental oxygen. So some of the complications here, you can actually create a pneumothorax if your diagnosis is incorrect. You can lacerate the lung or create a hemothorax. You can damage some of the vessels, nerves, or actually even the myocardium if you're not in the right spot. And if you don't use an aseptic technique, you can create an infection. So some of the tips and tricks, if you're working in a noisy environment such as an EVA, you may need to do a needle test to confirm your diagnosis. If the catheter kinks or gets blocked, you can flush that with some saline. And if you're unsure of which side to decompress, you can, it's best to basically do the right side first and reassess a patient and then do the left side. So here we've got a bit of a schematic basically outlining the landmarks that you're trying to get there. So look for your angle of Louis, that'll give you your second rib. Feel for your clavicle, mid-clavicular, between second and third rib is where you're basically aiming for. And as you can see here, basically inserting the dual cath there. What you need to be careful of is actually you've got a neurovascular bundle of nerves, arteries and veins that run along the inferior margin of the rib, so you need to be careful of that. That's why we go above the third rib. So I'll take you through the practical demonstration now. What we need to do is I'll take you through the needle test as I mentioned earlier. What you need is to drop some normal saline in a syringe and also give yourself a couple of centimetres there of space. So what we do is we connect up the dual cath. Okay, pop that down there. Now we need to identify our landmarks. Okay, so find the clavicle, work your way down into the second intercostal, over the second rib, in between the second and third rib, and you can also identify the second rib by the angle of Louis there. So you've identified your landmark using an aseptic technique. Give the area a swab, grab your dwell cath. Okay. Perpendicular to the skin, angling in towards the vertebral column, advance the needle in, and what you should notice is that you should get some bubbles in the chamber there. Okay, so you know that you've got a tension and it is in the right spot. What we can do now is advance slightly and then advance the Teflon. Now unfortunately, given the anatomy of the mannequin, I'm not going to be able to advance that any further, but what you would then do is tie that in with a little bit of tape. Okay, so to do that you just wrap around there like so. Okay, and then you would pop on it over the top an Asherman chest seal. Okay, so I'm now going to take you through a needle, decompressing using a needle. Okay, so same process. So identifying your landmarks over this side, clavicle, work your way down, second intercostal, over the second rib, in between the second and third rib there, mid-clavicular. Now a little tip is that it's actually more lateral than you would think. So using an aseptic technique again, clean the area, okay, angling in slightly towards the vertebral column, advancing. What you should hear is a little bit of a hiss, okay, which is basically all the gas escaping. Yeah, we should be able to advance that slightly. Okay, popping the needle away into the sharps container there. What you do is you tape it in. Okay, then we're going to pop the chest seal over the top. Okay. Okay, and what we're looking for is basically the valve opening and closing to show that the air is actually getting out, but the no air is actually getting in. And then what we hope to see is hopefully an improvement in the patient's clinical conditions and hopefully comfort. So it may take some time, but what you want to do is you auscultate the chest looking for nice equal air entry.